Thanks, Michelle, and welcome everyone. We have not just a great chai meeting today, but some really fabulous panelists who are going to be talking with us. It's pretty exciting who is going to be part of this conversation today. We have a few things to talk about before we actually dive into that. Just a quick reminder of some of the chai meeting guidelines for everyone. So first, obviously, if you haven't yet, please chat in your name and your organization. It's one of the ways we take roll call too at these chai events. So please make sure you make a note. If you're not already on the listserv for the Okanogan Chai, get in touch with Michelle or I. We're going to have a new listserv and some new kind of functions pretty soon for the Chai membership and network that will make signing up for Chai activities and following what we're doing a little simpler. As we talk today, we encourage you to put questions into the chat box as always. If you know the answer to those questions, please do share what you know and what you're thinking about. The strength of this Chai network are the people who are part of it. So we certainly rely on and hope that you share your expertise and what you know. So please put your questions in here. You're welcome to follow up, particularly on this topic with Michelle or I, if you have any questions or thoughts, concerns, aspirations for community health assessment after this conversation today. If there's any media present or any media joins, please make sure that you announce yourself in the chat just so the presenters know that you're here. We try to get our media to ask permission from our CHI presenters afterwards, or at least check in with them about what they're sharing to make sure that they can communicate the context of this big work. And lastly, at the end of the meeting today, we'll send out a meeting evaluation just to see if you got what you hoped you would get from the meeting, how we can improve moving forward. We'll send that out after every CHI meeting this year. So we encourage you, send your feedback. You can make it anonymous if you want, but please take a minute if you got anything to share. Okay, again, thank you everyone so much for coming. The first piece, I'm actually going to pause here and invite some folks from Aerometao. Cindy, are you on the call today?
I am on the call. Thank
Awesome.
you. Hi.
Okay, a bit of a quick introduction. Cindy and some folks from Aerometao are going to talk with the CHI membership real quickly. They just emailed us requesting some time to talk about a new item that's going to show up on the ballot this year. And just so you all know, the CHI doesn't take positions on any particular piece of legislation or any candidates. Cindy's here just to share with you all and give a little bit more information and background on that particular piece of that particular ballot measure because it has such an impact on community health, regardless of where it goes. So with that, I'll pass it over to Cindy, and then Cindy, I'll pick up next when you're done.
Yeah, and can you remind me how much time I have so I can start my timer?
Yeah, just about 5 minutes, Cindy.
Oh, perfect. I think I can do it in 5 minutes if you guys can think and read here fast. I think I get more nervous talking on Zoom with a timer going than I do in a large audience. But real briefly, just so that if you get asked and or you have any questions, Aero Methow Rescue Service contracts with the Methow Valley Emergency Medical Services District to provide services in School District 350 in the Methow Valley. Primarily emergency medical services, but as you all have seen lately, we've jumped into the public health world with vaccinations and COVID testing. I think it's probably best if I give a relatively short history, and then you can see how the pieces all fell together, because there's a lot of new people in the Valley and they don't realize how, number one, we're funded, and or the fact that the levy it's a 10-year levy. And so it's coming up for its renewal. It expires actually next year, so they're running it now. So the real quick history is, my name is Cindy Button, and my father was Dr. William J. Henry, and he moved here in 1960 from Whidbey Island Naval Air Station because he heard they were looking for a family practice doctor in a small rural area in north central Washington. And he had done a lot of work in the Alaska and Aleutian Islands doing search and rescue and so on. So it inspired him to be in a really rural area. So we moved here in 1960. His first office was right next to what was the Antlers Tavern, or the old Cove building. Shortly after we moved here, he built what is now known as the Family Health Centers up on Twist River Road until 1990, when he decided that he was going to go do something different for the last few years of his career, and did locotandem, and then he went to the University of Minot Medical School and to do what he called teach medical students to be real doctors, taught them how to sew and set fractures and do what family practice doctors in rural areas should do. Along with that, while he was at the clinic in the early 60s, He wanted to bring in a lot of stuff that he did in remote Alaska, and he found out that there really wasn't an emergency medical services system in the state of Washington and Oregon in the Methow Valley. So he and a group of volunteers that were actually ski patrol volunteers put together what is now known as Arrow Methow Rescue Service. And it's called Arrow Methow Rescue Service because at that time, another physician, Dr. James Baker, was joining him, and he was a test pilot with the military. And he was going to bring in a Cessna and helicopter. And he actually brought the Cessna in, and we did a few transports out of here in his Cessna, and the helicopter never arrived. And then Dr. Baker went on because he missed flying fast airplanes and went back to pathology school and also to be a test pilot with the military down in Texas. So that's a snapshot of the story. 1990, when he decided to go do something different, the Twist Medical Center is what it was known as, subsidized all of Arrow Methow's work. It gave us a home and did the supplies and everything. It was all volunteer. In 1990, when he left the clinic, Brewster Hospital took over the clinic, administered it until Dr. Jensen and another doctor came in. Dr. Jensen stayed, and my father gave the clinic to the North Central Community. It used to be called Greater Wenatchee Foundation, Central Washington Foundation, NC. You know what I'm talking about. The numbers, the acronyms aren't coming off my tongue right now. So I gave the clinic to them and helped seed a lot of the work that the Community Foundation in Wenatchee does. But we were homeless. The hospital told us we had to vacate the building. And so for the first time, been managing this ambulance service since 1984. We were literally homeless. We had no place to live, no phone, no nothing. We had to have bake sales to buy tires. Gene Lloyd let us live in a house for a little bit, which was soon demolished when they redid the East County Road, and that even left us more homeless. So we researched all sorts of options, selling it. At that time, Lifeline was a new ambulance service, and they said, "Hey, do you just want to take this over? Because we don't have anything." It was not financially feasible for them to take over. We thought about a subscription like what Lifeline and Airlift have, but that was a whole layers of legal mess. And running an EMS levy, forming a EMS district and running the levy was the only option that was going to be viable. So everybody paid a little bit to keep us in the valley. So at any rate, I have 18 seconds left. That cycles around. We'll have information on our website with more information, but without the support of the voters, we would no longer exist as we are known now and wouldn't be able to do all the amazing things that we do. So please direct people to our website if they need to know any information. And my timer is going off and I am done. And Justin, right here, sorry, I just, like I said, I get so nervous that I forget to introduce him. He's my deputy director. He's also available to answer questions, come to meetings, talk to you. And we hope to have our website answer all of your questions. So that's all I have. Thank you.
Thank you so much, Cindy. We appreciate it. Thanks, Justin. Okay. Before we dive into community health assessment, a few quick CHI updates for you all. Number one, we are going to be updating our membership agreements. So we'll be sending those out to the CHI network within the next month. The Leadership Council will get some approval on the final versions of them, but they'll be coming out to you all soon. Second, the CHI is going to be hiring a project person to lead just a 9-month project, following up on some of the earlier housing conversations we had as a CHI. So the role of this contractor, which you all will get to meet soon, will be to help think about ways for our county to come together and build more countywide approaches to some of the larger housing issues out here. So they'll be doing that in partnership with the CHI, the Housing Authority of Okanogan County, and some of the other partners. So I just leave that up lightly because they'll be reaching out to you and really thinking about how to convene more tables where communities can come together and think about housing policy, housing resources, and way to collaborate to take on some of the housing issues out here. It's also an experiment for us here at the CHI to see what role we can best play in mobilizing and helping to strengthen the work that you all do all across the community, really well that all of us do across the community. So a quick plug for that. Today, we are going to be talking about community health assessment. My hope today, or our hope today, is that one, by the end of the day, you will be thinking about what you actually want to learn from a community health assessment here in Okanogan County. And two, as you consider what you want to learn, what you want to gain from a community health assessment, all of us on our CHI network are informing and helping to guide all of the folks who are implementing the community health assessment. The truth is, the community health assessment is only as effective as its actual application to the community that it's meant to serve. So the purpose of the conversation today is really to lift up the ways in which this community health assessment can touch your relative work. And I want my job in this 30 seconds here is to transfer as much ownership as possible to that outcome to you all, and know that the partners who at the table here across public health have already demonstrated themselves to be pretty fantastic in looking for input and looking for guidance and wanting to turn the tool towards what's useful for you all. So if you're in childcare, substance use, housing, social services, healthcare, I really encourage you by the end of the conversation today to come back to your team, get clear about how the community health assessment could best benefit you. And then not just think about what this community health assessment can do, but start to join the CHI in thinking bigger picture around how we integrate health assessment and some of this community health data into our longer term work. Right now, the CHI is set up to bring in someone who can do some data work for us in the next 6 months. So we'll be learning a lot from this community health assessment process and hopefully bringing somebody in who helps move forward the goals that you all set for community health assessment. I think that is it for my brief introduction to community health assessment. With that, I'm going to hand it over to Michelle, who can tap me in at any point. Michelle and I are both coughing and sick, so maybe we'll swap in and out here as needed. Over to you, Michelle.
Yes, we are going to get started. So on our panel today, we have several speakers who are speaking to different parts of their expertise. So we have Luke Davies, who's going to be a part of the panel today representing the Chelan Douglas Public Health District. We have Lori Jones, who is also collaborating with Luke Davies on this regional project that Alana just mentioned. And we also have Dr. Wallace, a health officer for Chelan Douglas Health District and also part of Family Health Centers. Monty, who is the president and co-founder of the Community Initiatives Network, and Mike McNichol. Jesus Hernandez, also from Family Health Centers, also submitted some responses via email but could not be here with us today. And I'll be integrating those in as appropriate. And I just want to give everybody a broad overview. First, we're going to take you through and ask the panelists to talk about definitions and purpose of a community health assessment, so everybody has that shared understanding of what we're talking about today. Then we're going to talk about the impact. What is the potential impact of the ideal community health assessment? And then we'll talk about challenges, unique challenges to our rural community, but also what are the unique challenges that we face in asking the questions about those who are furthest from health opportunity. And then finally, I think what's going to be most exciting is the very end, where we'll talk about how do we get to that ideal? Where are we at now? And how do we get to the point where we actually can do the work of that ideal? And so I am very excited to hear everybody chime in today. Please put in those questions into the chat, and we'll try to integrate those questions as well. And so we're going to get started, and I'm going to leave it kind of open-ended for you all. So like if somebody is just super passionate about like giving their response for a particular question, please just pipe up, raise your hand, you go, unmute yourself and go if you are part of the panel. And we're going to start with the question of what is a community health assessment? Give us the definition you'd use for a kindergartner and the definition you'd use when talking with a mayor. And I'm going to integrate Jesus's response that he submitted for a kindergartner because I love it. And Jesus said for a kindergartner, he would define, he would say, a community health assessment asks many questions to find out who is hurting and who is not. And I love that definition. So I'm going to open that up to you all. And what would you add to the kindergartner definition, or what would you subtract And then also, what would you add for the mayor portion of that question? So I will open it up to anybody. Dr. Wallace, I saw you unmute.
Yeah, I really like Jesus's description. I could describe it as like when you go to a doctor's visit, and a doctor might look at you and evaluate how healthy you are and give you some advice on how you can be healthier. Our organizations do community health assessments in very much the same way. We ask what makes the community healthy and how can we make a contribution to making the community even healthier.
To this. So, you know, I welcome anybody else who, you know, is thinking about the answer to this question. If you have anything else to add, go ahead and unmute. I see Luke.
Yeah, so to add on to what Dr. Wallace and Jesus mentioned is, you know, for the individual, we talk about the individual and kind of a check, but for a whole community, I would liken it to looking around a kindergarten class and saying, you know, who's thriving and who isn't thriving, and are the reasons behind why they're thriving. So, you know, who's doing well, who's not doing well, and what resources do we need to bring to bear in order to help the people who are not doing well to improve. And I would use that for a kindergartner as well as a mayor to kind of talk about when we're thinking about a community, right? It's easy to kind of personalize it and make it about me an individual. But the reality is that a lot of community health assessments, we need to be thinking really broadly about what resources are needed, and not just in a healthcare setting, but in the lived environment. So that's why a classroom example, you have, you know, who's got access to the water fountain, you've got who's, you know, who needs to go down to the nurse's station, who needs to go outside and play, who needs nap time. So you can kind of have a much broader picture of what a community health assessment is outside of just healthcare. And when talking with different stakeholders or mayor, I would expand on that and discuss what kind of things do we need to be looking at, what stakeholders do we need to be engaging, right? So community health assessment can be as broad as, where is everybody doing? How is everybody doing? And you get kind of surface level answers. You get some people saying, I am really not doing well. And a lot of times the squeaky wheel gets the attention. Another aspect of community health assessments is looking at the underlying data, looking at the stuff that people aren't necessarily aware of, or maybe is there, but there are reasons why people don't talk about it. So I'll just bring up things like domestic violence, for example. Internationally, we do a survey called the Violence Against Children Survey. It's something that a lot of people know is an issue. They're really passionate about making sure that that doesn't happen. How do we prevent that? How do we do that? But when it's in their own neighborhood and they're asked about it, it's a very uncomfortable discussion to have. And so there are different ways that we can hone in on one specific issue during a health assessment and say, we're really curious about this. We want to assess this in a comprehensive way with rigorous scientific tools and methods. And then we want to make sure that our stakeholders who are addressing that, so your law enforcement, your healthcare providers, your social workers, your pediatricians, they all have input into that process, making sure that they say, well, it's really nice to have data about how many people are, or how many calls, domestic violence calls you have, or how many, that kind of stuff. But what I really need to know is how many kids need my help but aren't getting access to it. So pulling in those different perspectives and doing a large comprehensive kind of deep dive in one assessment is an example of where we could go. So that being said, a lot of that takes resources, and that I think comes out in some of the questions that you have later. So I'll go ahead and pause on that, but that's just an example of different styles of assessment that we can do.
Yes, thank you, Luke. So I think part of your answer talked about why. So why do we want to know who doesn't have access to the water fountains? And I'm going to turn to Monty and see, Monty, do you have anything you want to add to the mayor, the kindergartner, or to the question of why? Why do we do community health assessment?
Yeah. I'm glad that Luke went before me, and really appreciate what Dr. Wallace and Jesus started off. So I was also along those lines of, it's a starting kind of comprehensive snapshot of our collective health and well-being. And I think the why is really important, and particularly for mayors. I think in many cases, the CHNAs or community health improvement plans that are driven by a community health assessment of sorts often look like they are, something for the health department or the hospital. And I think for mayors that are paying attention and see themselves in this, it's a real opportunity to understand that this mind shift that I think Luke is describing, that looking at our collective health are really where there's opportunities further upstream, that people are not just healthy or unhealthy because of behaviors that they've made, but it's an opportunity to do some explicit and some stealth kind of mental model shifting. And that mayors and others that care about the health and well-being, which hopefully increasingly everybody in the community, that these needs assessments can be used to really make those investments around our collective health and well-being that can impact a lot of individual lives. And I think there are mayors that are seeing the value in that, but I think all too often, we haven't made the case for mayors or other sector leaders outside of health and public health to really see the value of CHNAs or CHAs.
And this is Laurie. I would just add along with that, because Monty, Luke, Jesus, everyone else has said pretty much identified things. But once you know your community, and that can help the drive an improvement plan and justify where you're putting those resources. And so I think that's really key for mayors, whether it's a city park or a road improvement or a housing project. It can help with identifying what those needs are so that improvements can be made and resources justified for those projects.
I was just going to quickly add to that point. We were involved for many years with the county where Nashville sits, Nashville, Tennessee, and for a long time, their mayor would use their community health needs assessments done by health departments and hospitals to justify investments in their healthy eating, active living, in particular, their bikes and trail systems, and demonstrating how that was improving and the impact it was going to have on the bottom line for the city. So they were really using those data pieces to justify and garner support for what is one of the larger, most extensive kind of greenway systems in the country. And they helped really shape some of those talking points for the mayor.
Awesome. So I hear in these answers, when for the why, a lot of we're doing kind of decision making. It helps us do decision making, especially around resources. Like if we're talking about financial decision making, if we're talking about infrastructure that needs some decision making from decision makers who aren't necessarily doing community health work, right? So mayors or commissioners, for example. And so one thing I think that Luke mentioned is also about access. And so does anybody else want to speak to that? It's about access and an opportunity to essentially hold a microscope to the unseen. Anybody, I don't know, Luke, if you want to elaborate on that point, because it might have been lost, or does anybody want to add to that piece, that element, kind of from a community health perspective, not from the perspective of changing minds, but from your own as people in public health and trying to change communities. Maybe your personal why.
Well, I appreciate that. I'll add just a little bit to that, and then add another item. So, we use the classroom example, right? So if somebody in the class doesn't have access to the water fountain, we ask, why don't they have access? Is it because they have a barrier that impedes them getting there? Maybe they're not tall enough to use it, so we need to get them a footstool. Or, maybe there is an issue with they can't get to the water fountain, so someone needs to bring them water to where they're sitting because they have an issue with being able to be mobile. And so there's kind of an equity lens to that access piece where it's not always, oh, boo on you, you don't have access or you're not giving access to these people, right? We're not talking about this in a shame perspective. We're talking about this in a logistically, how does this work for everybody to make sure they have access to these things that we all should have access to. And the other part that I'll mention on this is that, you know, not only talk about where we put resources, but also how we do policy. So whether it's at the county level, the city level, county level, state level, federal level, sometimes these health assessments or community assessments help drive policy decisions. If we can say, hey, you know, we've noticed that there's a lack of state investment in these types of things, and these issues affect multiple counties and states. If we collectively pull that information and say, hey, we need a state intervention or a federal intervention on some of these things. And, you know, just as an example, if you think about the federally qualified health centers, right? A lot of that funding came from advocacy in rural areas and different places saying, hey, we need another resource that's available to us in these areas where we have more work here. So those are the types of things where it's not just resources in terms of, you know, where are we doing our local resources? Sometimes it's advocacy for policy changes and our resources on a larger state or federal level.
That in the documents that got sent out around childcare in Okanogan County. And so any other, before we move on to the next section, any questions from the audience around definitions and purpose before we move on?
Michelle, I don't know if any of the things you'd sent out, but just why this hospitals, for example, are required to do CHNAs. I don't know if, you know, again, to justify their not-for-profit tax status in many cases to show community benefit. And I would just say that's a great opportunity. And I think that's a great challenge. We're seeing some of these challenges for the last couple of decades around whether that not-for-profit status based on those investments and those CHNAs are actually justified. Of course, Providence is under a lot of fire right now for some of that work, and I think they're not alone. But I think that the double-edged sword here is that out of a good intent to justify not-for-profit status by addressing the needs, particularly of sometimes the most vulnerable community members that are shouldering the greatest burdens of inequities, the process sometimes becomes a little bit of checking a box and sending that in. And that might, you know, come later on as we're talking about some of the challenges, but just wanted to add where this is coming from in some cases.
I really appreciate that, Monty. And I think everybody on this call, right, like we're all here together for that reason, because we know that in a sense, we all have to check a box. We all have to collect data, right? We all have to figure out if what we're doing, you know, is, you know, to justify more money or to justify, you know, to support our work financially, but also, you know, in our other, what is the ideal? Like, what is it really deep down? Why are we doing this? Why do we do the collection? So I really appreciate that. So let's talk about that. Let's talk about the ideal. If we didn't have to check a box. Oh, we have a question from Peter. I'm not going to skip you, Peter, with the good questions. Oh, you're on mute, Peter. I'm going to have you unmute.
My questions are better on mute. The question for the panel is, you know, we often think about identifying who's suffering and who's not, and about reducing disparities. But as part of the why, can you talk about why reducing disparities or solving those things benefits not just those who are suffering, but how it benefits the entire community? Sometimes I think that gets lost.
So I'll go ahead and just give an example. So one of the big things that happened over the last 15 years, we talked about kind of the Medicaid transformation and trying to make sure we have increased access to insurance and healthcare in general. one of the examples of just the healthcare system is that when you have a number of people who are uninsured or underinsured, and they end up deferring care, when they finally do show up and go to the emergency room, we've got data that supports that it puts a strain on our health system. So it ends up costing a lot of these hospitals, critical access hospitals or areas, specifically in rural areas, a lot of money to take care of these individuals who, had they gotten care before, or had they had regular checkups, or they had access, that they wouldn't have gotten to the point where they're now in crisis. We're seeing this now very acutely with mental health. I was just at the Chelan County mental health crisis, and they were sharing with us videos that were very graphic and challenging to see, of individuals in acute mental health crisis with no options, no resources. And so when those crises began, go out of the doctor's office or outside of a place where it's treatable, then it starts impacting the entire community. And it ends up making that, so with the more crisis you have, the less resources you have to deal with some of the upstream effects. So it pulls a lot of energy and a lot of resources towards that crisis. And one of the best examples that public health kind of uses to illustrate this is the village on the river model, right? You have a village on a river, and one day someone notices that bodies are floating by. And so they're like, this is horrible. Let me go see if I can help something. So they're pulling bodies out of the river, kind of this downstream, and they're just constantly doing this and going, man, this is horrific. This is traumatizing to me. The community then comes around, they're pulling bodies out of the downstream area. And finally, someone says, well, why is this happening? Why are we having all of these bodies come and float by us? What's going on? And part of public health's role is to go upriver and see what is happening up above, where we're having all of these issues downriver. And that cost, whether it's trauma, whether it's mental, whether it's fiscal, that has a big cost on the community that's being impacted by that. And it doesn't cost as much for us to do the upstream interventions and prioritize and put resources to that, so that we're not having to spend so much money on crisis care and crisis follow-up.
Return to that when we talk about challenges to impact. I think that's, especially when we think about why that is for rural communities, I think that will be very important to discuss. So in terms of the ideal community health assessment and the most impactful, how do we make the most impact with a community health assessment? Here, I'm going to ask you all to reflect on the impact that an effective assessment could have on Okanogan County. And so if you could think of your ideal community health assessment and answer the kind of real impact we could have, and also what sectors would benefit from that ideal community health assessment. And I'm going to actually, I'm sorry, I'm going to start, even though this is specific to Okanogan County, I'm going to start with Mike McNichol, who's coming to us from Grays Harbor. And Mike, I'm going to address your version of this question a little bit, because you're not from Okanogan County, and you don't know our community specifically, but you are coming from a community that has done, like Alana said at the beginning, we've been watching your Grays Harbor work. We love the assessments and the and what we see from afar. And so I'm curious if you can share with us a little bit about where you all are at in Grays Harbor in that process, and kind of and what you could potentially see for a community like ours, who's really trying to have this, we have this try, we're coming together in this space. Any kind of advice or reflection on this question? And if you could kind of give us a background on Grays Harbor, but also on yourself, that would be helpful.
Sure. Okay. So I'm Mike McNichol, Grays Harbor County Public Health Director. I've been in public health for 29 years, mostly started out in Kitsap County, moved around all over Washington and Oregon at public health systems. Had a stint in Clatsop County or Astoria, Oregon area for about 7 years, and then moved to Grace Harbor County. Been here for, it's going to be 2 years here pretty soon. So the reason why we started the CHA process is when I got here, the last CHA that was done here was probably over a decade ago. So there hadn't been any work done or an analysis done in Grace Harbor County for at least a decade or longer. And we have several issues that are pressing, quote unquote, by the decision makers that they think were necessary. And one of the things I really wanted to do with this department is make it evidence-based and driven by data. We want to be a data-driven organization. So I put together some funding to hire a consultant to help us put the CHA and CHIP together. We started this process last year. It took about 6 months to get together. And it was really, it was a pretty robust process. And one of the pitfalls of any process is community involvement. We wanted to have as many people involved in some of the say about what the community health assessment looks like. We had over 250 participants. So, for a county of this size, it should be bigger, but we can only do what we can do. We hit up as many sectors as we could, and we put together the CHA and the CHIP, and I put it in our chat here if you want to click on it to see what it looks like. Just today, we rolled it out to, as some of you might know, that a new law changed in Washington State where we had to expand our Board of Health at the local level. So I rolled out the new CHIP and CHA to our new local Board of Health. We have 7 members. And really the idea then is to look at the CHA, the data we have that was collected about all the issues that are affecting Grace Harbor County, both good and bad. We're supposed to look at both. And then look at the CHIP and look at the 4 priority areas and decide from a policy standpoint, what is in the public health wheelhouse, what we want to invest in as a public health department, what do you want to pursue as things that we can and can't do, and start going through a strategic planning process based on the CHIP, deciding what, for the next 3 years, what do we want to focus on? How do we measure success? How do we make improvements? Because Grace Harbor County also has the unfortunate position on the county health rankings as ranking 2nd from the bottom in the state of Washington. So we have a long way to go. And so anything we do is an improvement. And so really we're starting from scratch with some of this. And some of the things we found, as you'll see in there, is some of the things that most departments, especially rural counties, suffer from is lack of providers, lack of access. Housing is a problem. We have some health issues driven by lack of exercise and some other things. And, we have a pretty severe behavioral health and substance use issues in Grace Harbor County. In fact, we rank 2nd in the nation in methamphetamine use. So we have plenty in our wheelhouse to work on. So, so that's really what we're doing with the CHIP and the CHA, is really trying to prioritize work, develop policy, work at the policy level, and then do investments, because like most counties, we don't have a lot of money. Whatever money we do have is pretty stretched, pretty thin. So we need to make wise investments for what we do have. And then if there are specific things we want to do that are currently within our wheelhouse, we seek out additional funding through grants or whatever, and we go after those things. So that's sort of the story from Grace Harbor County.
Not know that about that community, and so I thank you for sharing all of that information. And I'm gonna kind of go broad to narrow, and so I'm gonna call on Monty first and ask Monty, again, somebody who's not from Okanogan County, and then we'll go narrower and narrower, and we'll finish with Lori, who's going to have the most specific answer. And so Monty, again, from your experience from other communities you've worked with, you can think of kind of an ideal community health assessment that you saw that had real impact to answer this question, and kind of, I guess, excite us, get us all geared up and excited for what a community health assessment could be for us.
Yeah. First, just want to express appreciation. Mike, thank you for sharing your assessment, just taking a quick look at it. Sounds like a really meaningful process and a great, result and way to kind of kick off some strategic planning. I'm trying not to go to your other question, which is what doesn't work. They are the same, different sides of the same coin. And I think when we first started doing this work, when with IP3 in the community commons, we started doing this with Kaiser Permanente and offered up a free CHNA tool that people across the country use. It was supported by CDC and others, and we overwhelmed people with data. And even it was pretty visually compelling. So people could pull up 20,000 data layers. It was one of the biggest, most accessible public databases before data became a commodity, increasing over the last 5 or 10 years, that you could pull up anywhere in the country, do food deserts, those types of things. And I think one of the things that we realized is that we had overwhelmed people with lots and lots of data. And those data were really a mixed bag of some things that were meaningful, some things that were out of scope, that were different data geographies that were combined. So we're looking at apples and oranges. And so the ideal community health assessment as a starting point, I think it gives us just enough of a comprehensive view of where things are currently to go into the inquiry of what those possibilities are with a broad set of, multi-sector stakeholders and really bringing in community voice. And so it is, I know, like Mike, we believe in data-driven decision-making. We think, I think in a lot of cases, the data-driven pieces that we expect the data to magically tell us what to do. And the CHNA and mostly secondary data, it just doesn't. It gives us, points us in the right direction. So I think the ideal CHNA is really helps us quickly orient to where there's opportunities for starting together for collective action. And usually if we can find those things, even if we started with food, invariably, we're going to talk about housing and transportation. So whatever is that unifying priority, good solution solves multiple problems. So CHNA brings together folks that allows us to kind of look at food in a more holistic way. And so just one quick example, and, so Greenville, South Carolina has a couple hospitals. And again, a lot of times because hospitals and health departments may be competing in some ways with their CHIPs and their CHAs, I think the ideal of health assessment is a very collaborative effort across health departments and health systems, which is sometimes easier said than done in competitive markets. But it's possible. And even if it's not completely the same CHNA and chip aligned, that they actually are really doing it in a collaborative fashion and how they're doing it. So the folks in Greenville, North Carolina, working with one of their priorities was really around all kids graduating from high school. Their 3 poorest middle schools realized that they were stuck in areas of concentrated poverty that had multiple issues. And the health department had been missing this data for a long time. And when they started to apply both their CHNA to go a little bit deeper, almost like Luke was suggesting, they started to really uncover what it would look like to take on concentrated poverty in some new ways and really engage parents and grandparents and others in that process, and then fund or seed fund some really innovative projects that over time through their CHNA, they saw some significant changes, not only in their graduation rates, but also opportunities to partner with the healthcare system around mentorships and other job opportunities around EMS and other things. So that CHNA was a starting point for saying, how might we invest differently in the places that would make the biggest difference? And last thing I'll say, I think coming back to Peter's point, folks in Greenville, South Carolina, we're seeing that, what is actually in our advantage. We know everywhere in the world where there's gaps in health disparities, where there's gaps in income, everybody's health and everybody's well-being actually goes down. Any way that we measure that. In a very individualistic culture, it's hard to make that case. But in places like Greenville, South Carolina, they did some case making to say, yeah, look at what's happening. What are the good things that are coming out of this that accrue benefit to everybody? Fewer ER visits, more graduation rates, reduced crime, more opportunities for people to thrive. So there is a case making that I think can happen through the CHNA over time that is not always easy to do in our culture. Sorry, that was probably a little bit of a long-winded answer, Michelle.
Really kind of wrapping back with the, how we're not going to have impact by doing kind of a broad overview, that it's going to help us. I'm kind of understanding that, similar to what Luke was saying earlier, we need to be able to use that to dig deeper into particular problems. And Luke or Dr. Wallace, do either of you want to start getting us closer to Okanogan County?
Yeah, sure. I could jump on because one term that Monty used that I really appreciate and think a lot about is the difference in primary and secondary data. Secondary data, as you mentioned, is that data that's out there. It's accessible to us. It might be in database form. We might have to crunch numbers, but there's data that's out there, and we can acquire a lot of that and use that to describe our community, describe the health of our community. But oftentimes it's not as detailed enough to really tell the true story of who our people are, what needs are, and what strengths exist in our communities. And that's where we can collect data ourselves. We can get primary data that is of Okanogan County. It takes more time, it takes more effort, but I think that's where we can really get into getting the voices of the people that really need to be heard in our counties and in the different communities within our county, so that we have a more granular, more detailed, and I think more relevant set of data to then move forward from. I think any health assessment, an ideal health assessment is going to deliver data that's actionable, that we can work on, that we can then develop interventions off of, and then we can repeat 3 years later, several years later, and then assess how well did we do on these things with these interventions and use it as a way to monitor. But I think an added benefit from a really well done health assessment is that it's a health assessment that we all contribute to. And it's a health assessment that we can all say, this is our health assessment. We've all made a contribution to the data in this. Our communities have contributed to the data in this. And just in the process of collecting that data, we collaborate and we form partnerships and we start the basis for those interventions that will ultimately follow it, because we've done this together, and the solutions we come up with are things that we're going to be able to work on together. And so I think an ideal health assessment starts at the beginning in inspiring, inviting that deeper engagement and collective action and picking up the data, so that then we can all work together on the priorities that we're driven by.
I think we can end there and just, call it a meeting. I'm just kidding. Yes, absolutely. Wonderful. Luke, do you have anything to add? I see you unmuted.
Yeah, so I mean, just to go off of Dr. Wallace said, and very simply in terms, the ideal community health assessment leads to informed, actionable interventions that move the indicators in the direction that we want to improve health. And, I think that's the piece of it. You can, as kind of Monty hit on with, you can collect all the data, you can look at all of these different things, but if it's not actionable, if people are drowning in this data to figure out, well, what do we do about these problems, then it's not an effective tool for the large part. So giving something to the communities, whether it's Okanogan or North Central Washington or Washington more broadly, where they can say, okay, great, I've got this information. Now I've got these evidence-based practices, or I've got this other idea of things that we want to try that may or may not work out, but at least we've got information to tell us that this is where we need to focus. Giving direction to groups to move their political will to do something actionable is an effective community health assessment. And so as we think about this, as we think about our stakeholders and engaging them in the process from starting, whether it's a steering committee or engaging them through focus groups or surveys or however we do it, it's giving them an end product that they can then use and say, okay, great, I'm going to advocate for my decision makers to do X, Y, Z, or I'm a decision maker. I'm going to say, okay, great, I'm going to prioritize putting resources in this area, as Mike McNichol talked about with what they're doing in Grays Harbor. It's giving that focused energy on how can we improve the health of our community and our neighbors so that we can all benefit moving forward. And we kind of talk about it in the North Central Washington EPI Consortium in terms of wanting to create kind of a CHA-CHIP cycle, right? Where your community health assessment does that. It monitors the health. We're tracking items over time where we've got secondary data, and then we're able to do these kind of deep dives or these community health assessments on a regular basis. Say, okay, great, here's these interventions that are happening. They seem to be working. Let's put more investment in them. Or, you know what, this isn't working out so well for us. We're going to shift focus and focus on this other issue that has become a top priority. And so making sure that we understand that it's an iterative long-term process. It's not just this one thing we do. We checked our box. Okay, great. We've got our nonprofit status or whatever it is, that this is really kind of a dialogue that we have utilizing evidence-based practices and approaches to improve the health and well-being of our communities.
I hear actionable. I hear this emphasis on primary versus secondary data, digging deep into particular places that the community knows we need to dig deeper into. And I'm going to ask Lori. Lori, if you are available, if you have anything to add before we open it up for other questions.
Sorry, I'm in and out. I'm like covering two different areas today. Anytime we're talking assessment, there has to be inclusivity. Okanogan, we can talk about how large geographically it is, but we are also demographically different in many areas. And so to make sure that we are, when we conduct whether it's a regional assessment or a county assessment, that we are capturing every group or demographic that we can. Otherwise, it isn't representative of the whole. And so I apologize for going in and out. But I think you would all agree, we are uniquely different. And when we're looking at our EPI consortium and planning for Okanogan County, we have to divide it into zip codes. And I believe we're looking at like 5 different areas because a large part of our county is Colville Tribal Reservation. And I really don't feel that we've done we need to be inclusive of everyone within the county. And there's so many unincorporated areas, and how do we reach those? So it's a challenge, but we need that input.
Thank you, Lori. I definitely think that this is an excellent segue for how we fall short, but also I'm hearing that the ideal assessment takes into account both the geographically diverse populations in our county, right? We have very within our geographic regions in our county, we also have a lot of socioeconomic diversity across different regions of our county. And then we also have, racial and ethnic diversity, as well as general cultural diversity in the different areas of our county. And Lori, I think absolutely, we all agree that we need to make sure that the ideal health assessment takes into account all of that diversity for sure.
And we have borders, not only Canadian borders, we have southern borders. So Bridgeport, for years, we've all said Bridgeport should be annexed into Okanogan County because Okanogan County serves that area too.
Absolutely. Absolutely. And I think this, Caroline mentioned in the chat, and I think this is coming up for all of us who are, answering these questions in the panel, this idea of how do we take it into account? So as you're answering the next question, which is challenges to impact, right? How are we going to get to this ideal, and what are the challenges that are uniquely faced? When thinking about this, I heard some of you mention that Dr. Wallace specifically is talking about process, that the process itself can be ideal, right? The idea of making sure that, you know, as a community, multiple entities are contributing to this work. So this can be our assessment rather than a particular entity's assessment. And so when you're thinking about the challenges of that, if you can also answer, like, who do we mean? Who do we mean and at what level? So are we talking about organizations who are a part of that process? Are we talking about people, like specifically community members who are furthest from health opportunity? And so the challenges to impact questions, we're going to take one of these questions first. And I'm going to ask the question of what are the reasons that a community health assessment might fail in its efforts to have impact. So we'll start very general. And I think I will start with, I'll start with Mike again.
I think it could fail to have impact if the lead agencies who are involved with and design the surveys and put the report together don't have the vision to then follow through and leverage their partners and community to engage in those priority areas that were found in the CHIP and the CHAW. So to me, it's about, you know, if there's not leadership or the political will is a big one. A lot of communities about, you know, is there political will to address chronic disease? Is there political will to address homelessness? Is there political will to deal with, you know, STIs and teenage pregnancy? All these really tough issues that seem to be divisive. Sometimes it's third rail politics. They don't want to touch it. So it's a matter of that's when it can fail, is if you don't have the political will behind you to address them. So, you know, we in Grace Harbor County is fairly conservative, but, you know, there are issues that span both sides of any issue. We can all agree that homeless is a problem, so that's something that we're focusing on. We agree that housing is a problem. We can work on that together. We agree that substance use and behavioral health are huge issues in this county, and that's something we can agree on now. The way we go about it might be a little bit different, but the end goal is the same. So within the milieu of that discussion, you can find common ground and find a way to get there. But again, that's where my concern was, is when we started this process, is that we wouldn't have the political will at the decision level to make changes and move forward. So that's why I wanted to make sure our Board of Health was one of the leaders, because the Board of Health has, by its mandate, is to protect the health of the community. So once you have policies at the Board of Health level, that can drive policy with community leaders to say that, yeah, we need to work on these things. And then it's just a matter of follow through with leveraging your partners to follow through with stuff that they agreed to do. And you can do that through goal setting and, you know, objectives and end of year kind of reviews and see where you are. So I think that's the key, is find your partners, make sure you get them to buy off on what was found. And even if they're sticky wickets and not comfortable, it's too bad. That's the way community, that's the way public health does. We're not the fun party. We're the most difficult party. So.
Answer. I heard political will, the problem of divisive issues, especially the issues that I think our rural communities face, and also accountability in action plans, and making sure that we leverage the work, and that people follow through on the plan, and then the common ground, making sure that everybody's playing a role in establishing common ground. Thank you so much, Mike. That was excellent. I think I saw maybe somebody unmute before I called on Mike, and I think it might have been Dr. Wallace.
Yeah, I did, and he did a much better job of describing, I think, what I was going to say. And that's the worst thing you can do with a community health assessment is do nothing with it. I've seen community health assessments be performed to check a box or because a regulatory agency requires that of you, and then it just gets shelved for 5 years until the next requirement comes up. And I mean, that's just heartbreaking because there's so much opportunity in that information. I'd much rather see a very short, small community health assessment done that then inspires action and that people can do something with, than see something big and robust that never, gets utilized. So I think whatever we do, we need to start with a commitment to do something with the results.
I'm going to switch the question a little bit here, and it's same topic, challenges to impact. And I'm going to ask the question, related to this issue of assessing communities who are furthest from health opportunity. I'm going to ask about in what ways can we do an assessment to address the biases that often arise when the assessor and community carry different power, experience, and expertise. And I think I'm going to call on, oh, it looks like Luke, you have yourself unmuted.
Yeah. So one of the things that is really important in this part, and it ties into the previous question as well, is methodologies. What methodologies are you using in your community health assessment to gather information, and also how are you doing so, right? If I decide that I want to have a survey and it is only available online for a short period of time, during the week or whatever, I'm creating barriers to getting input from specific partners. One of the questions that was asked earlier, by Peter, talked about, how do we get, why is it important for us to address these specifically, right? So sometimes it costs us a little extra resources to go to find the individuals who are disproportionately affected by our current structures or have been historically marginalized or other. And it's worth those resources to be able to understand what is happening with them, getting their input on what issues they're facing, what they're struggling with, and then being able to tie that into kind of the larger narrative. One of the examples I use is in a lot of third world countries, there aren't any systems that collect data on what's happening. You don't know vital statistics, you don't know who's born, you don't know who dies, you don't know who's sick. And without that data, no one does anything. No one shows up to provide medicine, no one shows up to do those different items. And so by collecting that information, by looking and specifically seeking out those groups who are harder to get access to for whatever reasons, it's important to bring that to the phrase. So we can say, hey, this is a really big issue and we need to address this or kind of focus on this. And I think when we are doing equity work specifically, we need to be thinking about what barriers are in place, right? So if it's a language barrier, making sure that we have tools and materials that are set in the language, make sure that we have methodology that includes reaching out to those different groups. We have ways of understanding where they are, who they are, and how to reach them. We think about unhoused populations or displaced populations, right? Making sure that we have a specific strategy and methodology for finding those individuals and getting their input or feedback or collecting information on them, whether it's a homeless count or some other type of finding where they're utilizing services and finding them there. And so making sure that your assessment is well designed to reach out and get those populations with primary data and really invest in those. The hard part, though, is that is really expensive. It ends up being a big barrier, and why a lot of health jurisdictions or others don't is because there aren't designated resources to do that. And so this is one of the reasons why some of these health assessments fail to capture that, is because you either have one person who's doing it, or there's not someone on the steering committee who says that's a priority, or there isn't budget for it. And so that can be a significant barrier in collecting that information.
Thank you so much, Luke, for naming that. Financially, a good assessment costs money and time, which also costs money. And I think that hasn't been raised yet. So thank you so much. Mike, you have your hand raised, I see.
Yeah, so just to let you know, one of the ways that we paid for ours is that, the state of Washington has made Department of Health has made an investment in local public health through the Foundation of Public Health. And one of the main things you can look at is what they want is people to update their chips and CHAs. So there is money to all local health jurisdictions to help do their CHAs and chips. Now, you're not going to get Cadillac, you're going to get Toyota. So just be aware that that's what you get. But, you can get a lot from a Toyota. It goes long distances and they're durable. So they may not be glitzy and fun, but that's what you get. So, and that's kind of what you have to do is you have to recognize that, some of these things are important to, but, no CHA is perfect. It's an iterative process. You don't get it all the first time. You revisit it in 3 years and try to do better. So I have to recognize you'll have opportunity in the future that this is, for us, I looked at this as like the baseline because we hadn't done one in 10 to 15 years. So this is our baseline, knowing that, we may not have got everything. We didn't get as many participants, but we did reach out to the tribes. We did reach out to Latinx, Hispanic folks. We did LGBTQ. We did all those outreaches that we could and did the best we could. We learned a lot and we'll do better next time.
Excellent. Yes, I think that's so spot on. Just being transparent about, where you're at in your process, I think is incredibly helpful to the communities when reaching out. Thank you. And I drive a Toyota, so I think, gets me around. Monty, I think you unmuted a little bit.
I hadn't, but I've driven Toyotas. I like Toyotas, so I'm with you. And I like the sentiment of, this can't be perfect. We keep building and iterating and improving how we do this. And I think that the data piece is, we know that place drives our health and well-being. It has a huge impact. And I think that's one of the challenges and opportunities, particularly when we look at county level data. We've been working with county health rankings for over a decade, and they recognize the challenges of that model. Is the more granular we get, the more insight we get into who's really where there's opportunities. And so just to say that I think increasingly we're going to see more place-based data at zip code and sometimes sub-zip code, unique geographies, and our ability to take advantage of data technologies out there, some of which are very inexpensive or free. Doing small area estimates puts us closer into the ballpark of where there are opportunities, equities, and inequities. And the faster we can take advantage of the secondary data, so we spend, again, more time with engagement and primary data collection, the better off we are. Caroline and Sarah and I were on a call this morning with one of communities I've been learning from a long time, which is Fox Cities, which is a 9-county region in Wisconsin. So for the last 15 years, ThedaCare, a large health system, has been kind of convening 9 health departments to do data in a day so that they're aligning their CHIPs and their CHAs with the health departments. And one of the things that I've always been impressed with them is that for 15 years, they've been doing these plunges where they're dealing with these kind of hierarchical differences. So some of the greatest innovations that have come out of that area are putting, the anchor institutional leaders in school buses and going and spending time in ways that are set up to be really honoring of difference, whether it's the Hmong population, where it's lower income minority populations there to really learn. And that has transformed the way they've invested. They've started to humanize this data. They started to pick up on these things. So over and over again, and they're starting to do that more on childcare right now and look at the intersection of housing, childcare, and food right now with investments from other private sector partners, all keying off their CH&A. So these, not expecting people to come. So I think that the idea of a lot of the engagement processes have become a little bit anemic. I'm all for focus groups. I'm all for surveys. They still kind of put us in the mindset of people are consumers rather than co-creators. So these plunges and things like that have really started to put money into people who are shouldering the greatest burdens of challenges, or the ones that are in best position to take advantage of opportunities to invest in and those populations to solve these problems and to actually cover the resources for them to participate in these engagement processes. So I think there's a lot to do on the process piece. Another piece I just add is that for this year, for the first time, and Caroline and Sarah are looking at this morning, they're looking at multiple frameworks. So they have very traditional kind of deaths and diseases of despair, which is what a lot of the CHNAs do. HEDIS measures or deaths and diseases of despair, which are deficit mindset, disease and body parts. And even though we have lots of social determinants piece, that language is important language. It's still the language of public health and healthcare. They're using the vital conditions and looking at primary data or surveys around thriving, suffering, struggling. So they're coming up with a new language, a shared language across sectors. They still have social determinants of death, of disease. They still have these other pieces. So I think frameworks that allows more people into some shared language around thriving, suffering, and struggling create some of that broader ownership and new possibilities for what mayors and council people, as well as grassroots leaders, are interested in talking about and how they get engaged.
That's excellent, Monty. And I think around that shared language also, engaging community in the language that they're using, right? Like not just, there is a framework, there is the vital conditions framework, I think, that can be taught, but also, communities using a lot of their own language. When talking about engagement, that sounds so exciting. That work sounds so exciting. So investment in community is what I heard. Investment in community around, the populations who are impacted the most, solving problems. What are their ideas for solving? What are they already doing to try to solve the problems? I also heard being transparent from Mike. Get that state Toyota funding for public health, and also it's an iterative process. Luke spoke about methodology and really making sure that your methods, you're being very mindful of your methods, that your questions and how you ask, where you ask, when you ask, all of those things, that you yourself are trying to think of the answers to that questions and who is going to answer with what particular method and when. And then also Dr. Wallace really saying that the worst thing that we could do right now is actually do an assessment that just sits on the shelf. And really, we need to do one that inspires action, and we all need to be committed to, even if it's just a small action moving forward, so that we can start moving forward with assessment. Is there any other questions from the audience before we move on to the most exciting part, which is how do we get from where we are to this ideal point? Any other questions from the audience that you want to pitch in or chime into the chat and ask?
Michelle, can I ask a quick question? This is
absolutely, Dr. Smith.
Mental Health Centers and Okanogan Housing Authority. My main question is, so the long-term versus short-term goals, right? So I always think about the idea of, okay, what's the Okanogan County impact that my children will see in 20 years from now, if we can create a place where they want to stay. And then what are the short-term goals? What can we do where we're going to see a change before that next, child that we perform, and kind of laying that out. I'm curious how people see some of these challenges. Where do we have space to say this is a long-term generational initiative versus watching a short-term change, right? We talked about this. Obesity is going to take almost a generation to really make a change in that, kind of metric. Yet, if we talk about access to transportation, that's something that might happen more in 5 years versus, hey, we're going to, create more opportunities for mental health care. Maybe that could happen in 2, right? If we can find some way to pull more people in to offer services. So how do people see that time frame in terms of action and what we expect to happen from that action, kind of given those time points?
Thank you, Dr. Smith. Can I take your question and contextualize it so it's like the most beautiful segue? Because I think it is. I think it is a beautiful segue. So we're taking the ideal, right? We're taking an ideal community health assessment that is action, all the stuff. We're getting to the point where it's iterative and can keep improving to the point where we are now. What kind of timeline? And you can correct me if I'm wrong, Dr. Smith, if I totally just, change your question. But what kind of timeline are we talking about from where we are now to our ideal to outcomes, right? Like, are we talking 20 years? Are we talking 5 years? And maybe just as an example in answering this question, maybe take just like an example problem, like you can say housing, it's probably 50 years. If we're talking about a particular issue, I've seen it done in communities in 5 years. I've seen outcomes within 5 years. So I'll kind of open that one up because that's a cool question, but it wasn't given to you in advance.
So I can just kind of start by responding to this. So, one of the things, I think a lot of it comes down to, again, political will, right? And you have this issue where you have what I call solutions looking for problems and problems that are looking for a solution. And the hard part is that a lot of times decision makers, whether it be an administrator like myself or a politician, right, they'll be like, oh my gosh, I heard about this great solution that's going to fix my problems. And then it doesn't really do what they thought it was going to do. Instead, you have a lot of people putting energy and resources towards that. So thinking you can find the actual proper solution, or you've diagnosed the real problem first, then informs what kind of length of time are we talking about. I think if we use polio as an example, or we can talk about smallpox eradication as an example for public health. Smallpox was identified. They figured out that if you had a vaccine, it was pretty much lifelong, and that you could go through and you could vaccinate enough of the population and create enough protection that you can eradicate that disease. And they did it from the time that they understood the problem to the point at which they hit eradication was about 20 to 30 years, where they hit full eradication. Polio has been a lot more complex. They thought, Bill and Melinda Gates Foundation have invested a lot of money of eradicating this globally, but things keep coming up in the way, right? So you've got conflict in Pakistan, you've got issues in Nigeria or Niger where you have these pockets of polio, and then you have live attenuated virus. Now we've got a polio case that's just popped up in Maine in the United States. And so some of these things where we think, oh, great, this is going to be a 5-year problem, we're going to fix it, there are unforeseen consequences to how we address those issues. In thinking about our specific area in North Central Washington specifically, if I'm thinking about workforce, right? So in order for us to get enough workforce to address the burden of disease, the mental health burden of disease, we first have to understand what is the mental health burden of disease in our area, right? How many people need different services? Can we solve it by having telehealth, right? If we had enough professionals or enough companies that had telehealth solutions where we could plug individuals in schools or families at home, if they have a smartphone or whatever it is, then the intervention could be, well, we could address this if we can get everybody a smartphone, right? That's an intervention. I'm using this as an example. And so it just depends on how technology changes. Sometimes the problem shifts. And so part of what we hope for this CHOP cycle is that as we identify, again, the baseline, like Mike McNichol said, create a baseline of understanding of what is going on. Do the big data analysis that Monty's talking about, where you've got all these secondary data that we collect. If we're able to harness that in such a way where we can say, okay, now let's start doing community-based interventions that can tackle these. It could be that we may be able to address these problems in a much shorter span than we actually think that we need to. And it could be that some of the problems we think are short-term actually are long-term issues. So I'll pause there, but that's kind of the perspective is understanding it is iterative, that there are things where it's like, yep, we should be able to solve this very quickly, but yet it's still a problem because of any number of different factors, but it's tying those in as we learn and have it being a learning process where we don't think, oh my gosh, we failed because we didn't solve this. It's this didn't work the way that we thought. We're going to try and shift it. And maybe it failed because it didn't have enough resources. Maybe it failed because it was the wrong intervention. Let's go back to the drawing board. Let's do an assessment to figure out what we missed and then what we need to do moving forward.
Thank you, Luke. Does anybody else want to attempt that question before I move on to the final question?
Could I ask another question, Michelle, whenever if you have the right moment is here?
Yeah, for sure. You want to ask?
Yeah, maybe before we go to the next one. So, we've talked a little bit about some of the, I think the possible implications in a place like Okanogan County around not just quality or even a Toyota level community health assessment, but ongoing assessment work that is rooted in community, continues to guide our investments, engages political will. And I'm curious, this may be a little bit of an Okanogan County question, but I have no doubt Grays Harbor, Chelan County, y'all have experience with this too. Why are we so far away from that standard right now? And I don't mean as in this upcoming community health assessment, but what are the conditions that are happening in public health and happening in rural communities that have kept us from being able to get to this standard for the past 15 years? And the reason I ask that question is I'm curious what habits or practices or conditions need to change for us moving into the future. But probably first, I would be really curious for you all who have had your feet on the ground in community health assessment. What is your take on what's happened for the last 15 years within this kind of community health assessment work, either state or local level?
I can give my perspective. I come in a little bit as an outsider to local public health from my global health perspective. And I can tell you that a lot of it has to do with resource allocation. When we think about in the global health scene, right, we had huge investments in HIV and the President's Emergency Plan for AIDS relief, where in the global health arena, we were pushing community health assessments in Africa and some of these other places through CDC, University of Washington, and others. And that field changed drastically over time. In the last 20 years, we've developed the Violence Against Children survey. We've developed a lot of these verified tools that are very successful in gathering primary data to help decision makers in some of those different contexts. While at the same time in the United States and Washington specifically, public health was gutted almost entirely in early 2000s in Washington state. And then again, 2008, 2009, we had another hit with the recession. And so we lost a lot of retained knowledge. The other component is that my predecessor, before I came in, when he first started my position and he would want to do, let's say, the secondary data analysis that Monty's talking about or others, he would have had to do manual chart reviews. We didn't have electronic medical record systems and that kind of stuff in place, 25 years ago. So we've got this advent where we've got technology and things that have happened, but we've had a significant lack of investment in public health towards this. So it's left us very anemic in some of these areas, specifically in North Central Washington. But as Mike McNichol was talking about, we have FPHS dollars now. We've got more funding for this. We've started a North Central Washington Epi Consortium with some of the funds between Okanogan, Grant, Kittitas, and Chelan Douglas counties, where we're bringing in epidemiologists to help do this. Jeff Taylor Kantz is one of the EPIs that we've hired to help support the Okanogan Community Health Assessment and other work. We've also brought in the University of Washington to help us look at the different tools and really evaluate and kind of start from the ground up about how we do our secondary data analysis and what that looks like for North Central Washington. And so we're kind of rethinking how we do this and how we reset our baseline. And between 2009 and 2019, we had 3 community health assessments that kind of gave us a picture of where we're at, but I don't know that those translated heavily into a lot of action. I think it did in some places. I think there are some partners who were able to take it and do a little bit with it, but not in a large cohesive way that I think Mike is seeing in Grace Harbor and we're seeing in some of these other areas. And so I think a big part of that, again, is as public health gets those resources back and we have the personnel to build relationships, because it really is about relationships and stakeholder engagement, we're going to see a transformation from we haven't had this, it's been very anemic for a while, to now we're getting something that's actionable and we're bringing people together to really help solve these problems in our local areas. That's at least the hope.
Thank you, Luke.
I don't want to stop you from pivoting, Michelle. So if you want to put your other question and I can.
Oh, no, you can absolutely.
Yeah.
Answer.
I'll just say that, through IP3 for many years, we did all the Kaiser Permanente's community health needs assessments. That includes in all over the Northwest, Colorado, California, and Bill Solomon, who used to lead a lot of their work there, would say that Kaiser, as much as any organization, was fully bought into place-based equity work and investments. And yet, if they looked at those investments and had to be honest with themselves, they would say that they really would be very difficult to justify those investments in terms of the impact on the populations. One of the things that, among many complicated factors are, they, to kind of use this medical notion that their investments were not dose intensive enough. There was some interesting stuff around some stuff that might address a barrier to food access, but it wasn't surround sound enough. It wasn't strong enough to actually tip the cultural behavioral change. And even Kaiser, that has a fair amount of resources, just wasn't partnering enough with others and had a long range view enough to actually tip the cultural change that was actually proving to be challenging, certainly for the lives of those people that were still struggling with lack of food access or lack of food, housing security, et cetera, et cetera. So I think increasingly, this question of what is a balanced portfolio, because just like in our corporate sector, our capitalist society, we tend to look at the next quarter. We are very short-sighted. And I think one of the things that we can start to see in CHNAs is how do we balance urgent services, those that are really suffering and struggling. We have a moral obligation for those who are suffering from housing or food insecurity, and our CHNA should help support that, catalyze innovations around that. And, back to the kind of village analogy further upstream that I think Luke was talking about, how do we look at these long-sighted investments that could be generational in nature? And that's the thriving together that we've been talking about, that we've been doing a lot with Rethink at CDC and others, that now is a bridging framework nationally for all the federal plan for long-term recovery and resilience. A premise is that we cannot urgent service our way into thriving. So a lot of our resources are trying to deal with urgent services that will ultimately never move people into a thriving category, no matter how you measure that or the experience of thriving. So I think a balanced investment can happen with CHNAs. And there are groups around the country like Florida and Michigan, regions of that are leveraging hundreds of millions, if in case of Michigan was $1 billion around a shared investment portfolio that has their hospitals, their health departments, their private sector investors, the United Ways, other community foundations, and their steady state resources into a shared language portfolio that looks at a long-term view. And so I think we're going to increasingly see these investment portfolios that are not just kind of locked into these episodic whenever we need to have a CHNA due to, a federal requirement. And that partly is making those data sets available all the time to all partners in ways that kind of overcome some of that turf, not just for a CHNA.
Love that. Okay. So thank you for setting up that question, Alana, because I think we needed that content. Like, where are we at right now? Where are we at in our community right now? Because the next question is, in what ways does our current plan or where we're at right now in terms of assessment, either, as doing a CHA, for Okanogan County, or even doing our, more sector-based community health assessments. Where are we at right now, and how does this plan differ from the ideal approach, and how do we get closer to the ideal? And I think I'm going to pick on Dr. Wallace. Haven't heard your voice.
Yeah, so I think there are a number of our organizations that have done community health assessments. Might have a community health assessment upcoming in the near future that they're required to do. I think we're probably all going to walk away from this meeting pretty excited about community health assessment and the opportunity that we have. And so I'd say, in my impression, where we are right now is thirsty for a really good community health assessment, a desire to see what we have in our knowledge about what community needs exist, or what community issues are at the forefront. My guess is that we probably have an agreement on those things. The CHI's done such amazing work over the past 2 and 3 years to elevate a lot of issues that some of us weren't as aware of, and inform others about some of the good work that's being done in the community. I think our level of knowledge is higher than it was a couple of years ago. And so we're kind of primed for this right now. I think the missing piece is that question of how do we engage with the people? How do we engage with our consumers, our patients, members of those communities, especially the communities that are not always represented in the easy ways of assessing community health, and what are the steps we need to take to design and then quickly move into a data collection phase.
Excellent. And thank you for that nod to the CHI. And yeah, I think we could probably, if we were to sit in this room and, you know, drop in some issues, I think we would have some kind of consensus around probably a top 5, for sure. Luke, do you want to pop in and kind of give like the vision behind, you know, really what is pushing us towards, what is the ask, and also maybe even Jeff, if you want to unmute, I think you got introduced earlier, and so people just know your face. Do you want to give an overview and kind of give some additional information about, you know, from the work that you all want to do?
Yeah, I'll go ahead and start us off and then have Jeff chime in. So I think one of the things that we want to acknowledge is that, you know, public health has been tasked with a really heavy lift with COVID, period. And so it's taken a lot from myself and my colleagues to make sure that we are doing everything we can to manage the pandemic that we're in. It's also reshaped a lot of our organizations. Chelan Douglas more than most, in the sense that we've had a lot of turnover and what that looks like. And so as we started ramping back up to look at assessments, a lot of our partners in the area have already completed their community health needs assessments. So a lot of our FQHCs and hospitals, critical access hospitals and Confluence, have already are in the process of finalizing their CHINAs. And so with that, we know that there's been a lot of information that's been gathered already. We don't want to duplicate or recreate that work. As Dr. Wallace and others have said, we don't want to be doing something that, again, we're going to take a look at and we kind of put back on the shelf. And so the direction that we're going is what we're going to be calling CHA Light. For this year is we're going to be going through and taking a look at a lot of those different assessments that are coming out. Some of them are looking at access for critical access hospitals. Some of them, like I believe for Confluence, is kind of a general health priority list look. And so we're going to be pulling information from these, looking at how they did, and we're going to be summarizing those. We're also going to be creating some focus groups and some key informant interviews to address some of the issues with our populations that maybe weren't included in some of the data collection, just based off of the methodology that's there. And so the other part of it that I'll just talk briefly about, I mentioned earlier, is that we are creating kind of a dashboard system with the top 25 most noted community health assessment indicators. And then we'll be expanding that list as we move forward, and currently working with the University of Washington to have that available for each health jurisdiction in North Central Washington. And so we're working simultaneously on the secondary data piece that will hopefully be updating every year, and then kind of doing that child light. And then the next thing that we're going to be doing is potentially looking at a deep dive in the area of mental health, as that has been in the top 3 issues for the last 10 years for North Central Washington. It came up as one of the top issues for these current CHAWs. But I think at the end of the day, we want to make sure that we're hearing from you guys in terms of what you need and what you want to focus on. And so if there is an area or mental health isn't the issue that you guys really need focus or depth on, we want to hear from you guys. What is it that Okanogan really wants to take a look at, and be able to focus and address that? And then we're also gearing up in preparation for our 2025 CHA. And there we're going to be looking at getting a larger cohesive group together with the healthcare providers and others, and funding a more comprehensive potential household survey that goes out and addresses a lot of these issues with really robust methodology and that kind of stuff. But it is going to take a lot of resources. And so that's something that we're trying to figure out now. Again, we're doing kind of a CHA light because a lot of data has already been gathered, looking at that, potentially doing a deep dive into mental health. And then also 5 years from now, getting a steering committee together, not only just for Okanogan, but regionally, where we're talking about what do we want to take a look at? How do we want to address these issues moving forward, all while building that secondary data database so that people have access to that as we move forward.
Thank you for that overview, Luke. So if anybody has any specific questions for Luke, if you can drop those into the chat. I'm going to turn to Mike and Monty to see if you all, knowing kind of where we're at, and you know, we talked about the ideal for our community. If you have any pieces of advice that you'd like to share, or kind of any insights that you think would be helpful in getting us to the point where we're at right now, to that ideal.
Well, I can go first. So, you know, because we didn't have a lot of history with CHAWs and CHIPs here in Grace Harbor County, and we wanted to get it done in a relatively short period of time, knowing we had a limited budget, we hired a consultant to do the work for us. And, you know, I think the advantage of that is it gets whatever politics goes along with agencies, between agencies, jealousy, past, you know, I'm not happy with public health, or hospital doesn't like us, or whatever. All that stuff goes away. So it made it a little easier to get better participation when you have a consultant involved. And we found that, you know, more people, more of our partners at the provider level were interested, were more willing to participate. So, but again, you know, I would definitely agree with Luke that this was probably a CHA light because of the timing. To really do it completely thorough would be a little more engaging with the community, have more forums, you know, we did an online survey, we did forums, we went to the fair, we did all kinds of stuff to get people to participate in engagement. And, you know, I think we can do better. But you know, I think in, let's see, this is 2022. So, you know, in 2025, we too would probably be looking at reiterating and learning from that. And I think, you know, if you can find a contractor to do it, it takes the pressure off the organizations. And it gives a little more freedom for the contractor to follow your methodology and hold them responsible to make sure stuff gets done, so that you don't feel the pressure internally. And that's why we were just, you know, and that, of course, you have to look at it from a COVID. We were doing it during the COVID pandemic, so we had to have help from the outside because there's no way we could have done it. So, and you know, you're coming out of the pandemic allegedly, so you might be able to find that if you had the internals staff to do it, you could do it. But there is an advantage to having someone else who has that experience to help you out.
Thank you, Mike. And I'm going to turn to Monty.
Unfortunately, I didn't get to hear Luke's answer, but everything Lucas said today, I've really resonated with. So I'm sure it was really good. And I mean, just knowing there's quite a bit of capacity in your county, you know, thinking about. So, I mean, there's a lot of assets to build on. And I think trying to figure out how you pull in some assets into your CHNA, just like asset-based development work suggests, you know, it's hard to actually do anything if you're focusing on all your deficits. And so may sound trite, but I think really trying to figure out where there's energy to take something on, and the data may not always tell you that. So maybe this year I heard the CHNA or the CHA Lite. What are some ways to positively disrupt the kind of rote CHA process? Not to say, you know, not knowing all of the history. So what would be new ways of engaging underheard experiences? What would be one really juicy intersectional issue, whether that's around workforce, to really think about how workforce might be tied to transportation and childcare and the next generation of the pipeline of representative community health workers. So what would be one issue that would allow the community to start to think about solving work differently, multiple investors, that I think would disrupt the typical way that kind of shorter term CHNA solutions tend to be. And Mike, I'm really impressed with your CHNA or the report, and sounds like a consultant worked well for you. I would say that I've seen in some cases the opposite, where the consultant did all the work. There wasn't a lot of energy put into it. It lended itself to kind of just letting somebody else do it. And so it didn't create the energy. And there's a lot of tools and technology. You know, we kind of moved out of the CHNA consulting business and make it really easy for communities to access their data, reconfigure that data, do it themselves, and really focus again on the engagement side of this. And so I would encourage you to kind of look at a lot of different options, including the Toyota version that Mike is talking about, but just to put more emphasis on the kind of greater meaning making with some different voices that typically are included in the process.
Love that, Monty. I think that for sure, if we were to pull a top 5, and if we're talking about intersecting issues, workforce would be on there for sure. For this try, it has been one of the main topics that has come up for every single one of our partners. And absolutely, it's had a devastating impact to everyone. So thank you for that. Luke, I see you unmuted. Is there something that you wanted to add?
No, I was just lost in thought. Appreciating Monte and Mike's responses and the conversation.
All right. Well, I think that I'm going to take a final poll for anybody who wants to add some final thoughts or questions. I'm also just going to quickly look at the chat to see if we missed anything in the chat. You see Brad did a shout out for Grace Harbor CHA for including childcare. And again, I think childcare is an intersecting issue. It's an issue that is unseen, kind of like what we were talking about earlier about domestic violence, even though it's something that, you know, is not like domestic violence because we talk about it, it's unseen because it's kind of an accepted part of our society. Like we've accepted the state of childcare, but it is impactful. Let's see, anything else? Alana, do you see anything else that I missed in the chat?
I don't think so.
Okay. Final comments from everybody. Jeff, do you want to say hi to everybody? I don't know if you got an opportunity to say hi.
I haven't yet. Hello, everyone. I'm Jeff. I'm the new regional epidemiologist. I work with both Okanogan County and Chelan Douglas Health District. So I'm very excited to work on the behalf of our community. Thank you.
Thank you, Jeff. So I think moving on from here, what we want to do is to, we're going to be reaching out to our sector leads. So those are people representing major sectors of the CHI and kind of doing a little bit of a deeper dive. But if you all want to send us emails of, just send us an email. Alana said she's going to put out the that I mentioned earlier that you'll be receiving an email from her email address with the poll. Send us feedback. Send us your comments about like what would be that juicy issue, or in your top 5. Go right ahead and send that over. What is in your top 5? And we will definitely be meeting with sector leads to kind of dissect these issues a little bit more.
And in general, the CHI is going to hear a lot more from us about this. I think that you all are out here, so we'll be continuing to point all these great public health folks towards the CHI network in many, many ways, and doing what we can to keeping the momentum moving forward after this community health assessment and the next one and the next one.
Yes. Well, thank you all for joining us today, and we will give you 7 minutes. 7 minutes to have a break.
Thank you.
Get healthy.
Thank you, Dr. Wallace. Thank you, Mike.
Thank you all.
Bye.
Thanks, everyone.